So this is a patient that is on OptiFlow. We're trying to wean the patient off of the ventilator. So we're going to put the patient back on the ventilator now that we have the reference with the OptiFlow. And we're going to find the parameters on conventional mode, and we'll try APRV also and see which one recovers all of the lung recruitment so that the patient, when they're going back on the vent, they're properly rested and optimized for the next OptiFlow trial. So we did a PEEP study on pressure support right up to 20. We were unsuccessful in improving anything on the left side. We transitioned into APRV, and we then started with a P high of 20, and we gradually increased it by 2, and we're looking at the end of inspiration to see if we have improved recovery. This goes over here. This was when they were on OptiFlow. We can kind of look at here. I'm scrolling. So this is at a P high of 30, so we're going to recruit. So we see that the lung that was previously closed over here has opened up with APRV. We were using a peak pressure of 26 because we had PEEP of 6 and PEEP of 20 and a pressure support of 6. The thing is, with conventional ventilation, you have the ability to recruit with pressure, but you're very limited in time because conventional modes, maybe 1 second, 6 to 1 seconds is the inspiratory time. And if recruitment is pressure over time, we're limited in conventional ventilation with a limitation on time due to the inspiratory time setting. But with APRV, we are able to benefit from true alveolar recruitment or lung recruitment because now we have the pressure that we have controlled, and we also have time, so that the slower recruiting compartments that require higher time constants can be recruited. We can't get that. And we're trapping 75% of the peak expiratory flow during the releases, and the study and the science so far behind it is that we can recruit with pressure over time, and we prevent de-recruitment by such a brief release, trapping 75% of the peak expiratory flow, and that keeps the alveoli that are now getting recruited from collapsing. Another important thing is, if you look at over here, we'll pay attention to the tidal volumes. If you first put your patient on APRV, let's say the average tidal volume during the releases are 350, and then you come back in the next hour, it's 480, and then 600, and then 800 maybe. So you know that everything else has been remaining constant, so the increasing tidal volume is also indicative of alveolar recruitment. They say 6 to 8 is for protective lung ventilation in conventional mode, but if you have a loss of alveolar surface area because it's not optimized, then you have a lot of alveoli that are not taking part in ventilation. They're collapsed. We're not getting air to them, so obviously all the other alveoli have more stress to deal with. They have to take that tidal volume and disperse it among themselves, and there's less of them. So if you optimize alveolar recruitment, and you're looking at it with the EIT, so you're getting information about recruitment here, then the alveolar tidal volume, which is the most important, is that more alveoli, that tidal volume is even more evenly dispersed, the job, the work, the stress, the power, and that means that each individual alveoli have less tidal volume to deal with. So there's global tidal volumes at the vents setting in, but there's also important to think about the micro level, the alveolar tidal volume. The minute that you're recruiting more alveoli, then the whole alveolar system has the job, the work dispersed more evenly. So we're seeing definitely this opening up on inspiration, but what we're trying to do here is the end expiratory lung impedance, which represents end expiratory lung volume. And here is the patient when they're on OptiFlow over here. And then after, you see over here in green, this is the incremental PEEP trial that wasn't really successful in opening anything up. If you look from here, starting with the reference at the same place as what we're checking, we start scrolling. Here we're transitioning from the highest PEEP over to APRV. And we're still having trouble recruiting here. There's definitely a lot more recruited in the ventral to mid-dorsal area, but we're still trying to recruit the base. We're seeing some here recruitment. We're seeing global impedance values that are a lot bigger, so we're definitely getting a global increase of end expiratory lung volume. The majority, though, is going over here to the mid-ventral. That's good that there's a mid-dorsal, so we're opening up the middle of the lung. Hopefully, after this is properly recruited, we'll be able to start recruiting here more. We want to see positive numbers starting to appear. We're not getting that yet. So over here is the customized analysis where we're going to evaluate everything that we've done over here. You can see that all of these are markers at different vent settings. Over here we're starting with OptiFlow, and then we're starting with the reference PEEP of 6 that we were using, and we titrated that all the way up to 20. Then after we transitioned to APRV, you see the loss of the green PEEPs. And then after, you see everything is pink here. This is the titration of your P high from 20 to 30. And now we are staying on 30, and we're trying to recruit. We've managed to recruit much better on inspiration, but we're still having trouble increasing end expiratory lung volume to the dorsal region, which is optimal. But here we see A, and then after B to G, B all the way to G, there's some improvements in compliance. It seems to be maintaining itself here. And then when we transitioned over to APRV, which is 8 to M, you see H, 24%, 53, 69, 83, 100, 140. All of this is an increase in compliance. Underneath here, we have to go to end expiratory lung volume, but over here represents your functional residual capacity. So if you're creeping up higher and you're seeing it trend upwards, right away you know you're getting some kind of recruitment. So the blue here represents a compliance win, and the compliance loss would be in orange. So you don't want to see loss of compliance throughout the lung, you want to see blue increasing. And when we come and look at the images, we see that with the higher P highs, H, look at the increase. As you go higher and higher, you're getting a lot more even distribution of tidal volume until we get to here. So this is how we do the PEEP studies.